So anyway, so I'm Samantha Canarek. I'm one of the interventional spine doctors. I mean, pretty much I do all non-operative spine for Brielle Orthopedics. And so this talk is really meant to be very practical. You know, I'm not going over all the latest research. I want it to be practical. I want, and actually it's very good that there's a spine surgeon here, because there are a lot of times when spine surgeons order tests or recommend procedures, and there's a thought that maybe, oh, you know, someone would benefit from an epidural or would benefit from an EMG. And I think sometimes maybe it's hard to understand, I guess, what other specialties do. And so I would like just to kind of inform everyone of what the purpose of various tests and procedures are, so that they're ordered appropriately and everyone has a better idea. So the learning objectives are to understand the basic indications for consideration of indications when it's appropriate to refer to an interventionalist. So how do you know when someone needs an injection, essentially? Understanding the role of EMG and nerve conduction studies in evaluating common orthopedic symptoms and diagnosis, and when it's appropriate to refer for an EMG. So the first rule I always say to everyone, especially the PAs or residents, if I've ever lectured residents, is know what you're ordering and why you're ordering it. Is it really going to change how you're managing the patient, or are you just ordering it because you're not sure why you're ordering it? The next rule, which is probably more important, is that if you don't know, you just have to ask. And I always tell the PAs that I'm always available. And so there are common spinal procedures. These are the big ones. There are obviously other procedures that some of the other pain doctors do. There are epidurals, there are facet joint injections, radiofrequency ablation, which is a facet joint procedure. We're going to go into detail over these. Sacroiliac joint injections, spinal cord stimulators, and then kyphoplasties. So this is a fluoroscopy machine. This is a machine that essentially all spinal procedures are performed under. In the old days, people used to do blind injections. Not only were they potentially dangerous, but a lot of times ineffective. And so you would have pain doctors 20 years ago doing blind epidural steroid injections, and you could have certain complications such as puncturing the dura, having spinal headaches, having myelograms, or even situations where you were just not in the epidural space to begin with. And so a lot of the earlier research on the effectiveness of epidural steroid injections is not even valid, because the research was done on blind injections. And so how did you even know you were in the epidural space? Fluoroscopy machine is very expensive. Patients will always come in and they may see me in a satellite office where we don't have the fluoroscopy machine, and then they complain why I'm not doing the injection the same day. And it's because that machine is probably a $200,000 piece of equipment. And so most offices are not going to have one in every single office. So the first procedure we're going to talk about are epidural steroid injections. There are various kinds of epidural steroid injections. I'm not going into details in terms of how to perform the procedure or all the specific types. I just want you guys to understand why you should order them and what they're useful for and what they're not useful for. This is a diagram basically of a transforaminal epidural steroid injection. So the needle is essentially going into the intervertebral foramen. You're injecting steroid or cortisone, whatever you want to call it, reducing the inflammation and hopefully reducing the neuropathic pain. Epidural steroid injections, they are, I think, along with other spinal injections, unfortunately, they're very overutilized, which is why we've seen cuts in reimbursements over the years. They are really good for one indication consistently, and that is for radicular pain. So pain down an arm from a cervical disc herniation, pain down a leg from a lumbar disc herniation, but they are just not good for chronic neck pain, chronic back pain that's just in the axial spine, and even questionable if they're really good for pain down an arm or a leg from chronic spinal stenosis. I mean, they just don't last, unfortunately. You have to really watch out for the patients who have uncontrolled diabetes. And the reason for that, it goes beyond just raising their blood sugar. When you're doing any type of cortisone injection, you are increasing that patient's risk for spinal infections. And so it's one thing if you have a soft tissue infection, but if you give someone an epidural abscess, I'm sure you could attest to that. That's life-threatening and that's functional threatening. Someone could easily be paralyzed and it could ruin them, and they will be way worse off. And so pretty much the Spinal Interventional Society guidelines are You do not do an epidural steroid injection on anyone with a hemoglobin A1C of greater than 7.5. And so if I have a patient who has a hemoglobin A1C of greater than 7.5, I will say no. And I may say, well, if you get your diabetes under better control a couple months later, show me, your lab work, and we could then do it. But if it's above 7.5, I can't do it.
Do you get that on your preoperative labs?
Usually what I do is that's a good question, Brian. Like normally what I do is I just ask them what their A1C is. If the patient seems completely unreliable, I'll call their primary office and just have them fax over their latest A1C. If it's a reliable patient and they're like, oh yeah, it's 6.5, then yes, we're fine. And so, to some degree it's on the honor system, but like you kind of know when you need to really dig deeper. The other thing is any type of spinal injection in the epidural space, you need to hold certain medications. Everyone is different. I, again, follow the Spinal Interventional Society guidelines. I hold anticoagulants and certain antiplatelets. So I will hold Coumadin, Pradaxa, Eliquis, Brilinta, Plavix, full dose aspirin, but I do not hold baby aspirin. I do not hold the NSAIDs that are used for pain relief, such as naproxen and diclofenac, and that's, again, based on the guidelines. There's some people that hold absolutely everything, and so everyone has their own opinion. There's some thought. You really have to think about, okay, how beneficial is this injection going to be? Are you treating chronic low back pain that doesn't have any radicular symptoms, and you now need to take this vasculopath diabetic with heart disease off of their Coumadin that they're on for a reason? Because you know what? Them being off their Coumadin might be a huge risk that's not worth taking. But then I can't do an injection with someone on that medication. And so there are times I have to explain why, again, I cannot do the injection that they want. So you have to think about the risk and the benefit, and the risk better not outweigh the benefit, or else you should not do it. So that's epidural steroid injections. Any question about epidural steroid injections? The bottom line about that is acute radicular pain from a herniated disc, they're fantastic for that. Other than that, they're very questionable. So a spinal stenosis, actually one other thing about that, one of my former colleagues where I did my residency in Seattle, Washington, did a big study on epidural steroid injections for leg pain from spinal stenosis, and essentially they found it doesn't work, unfortunately. And so those neurogenic claudication symptoms when the patient's trying to walk just does not work. The average length of benefit was like a month. And so those are patients, they're now saying, that are better off just getting functional rehab and even better off getting spinal decompression than getting repeated epidurals. We've all had those patients who've had 9, 10, 11, 12, 15, 20 epidurals over the years. They have severe spinal stenosis, and they wonder why they're not getting any better. And so if a patient comes in, has bad spinal stenosis, has claudication symptoms, but in a radicular pattern, not just my legs get heavy, an epidural is never going to work. A lot of times I'm saying, well, how many injections have you had? Okay, you've had 3 over the past 2 years. How long did it last for? If they say, you know what, I've had 1 a year, it's lasted me, each one for a year, then I'm willing to inject them. I think that's reasonable. If they tell me that the first one lasted for 6 months, the second one lasted for 2 months, and the third one lasted for 2 days, then that's maybe someone who just needs to see the spine surgeon if they've done all of the other rehab that they need to do.
How long do you wait between injections?
Well, good question. So if I'm doing it for an acute radiculopathy from a disc herniation, usually it's a minimum of 2 weeks that you wait. And so, and insurance companies will dictate also. So Blue Cross Blue Shield Horizon will not allow you to do an epidural within 2 weeks. In the old days, people used to do them like every week. They used to do them once a week for 3 weeks. They would do a series of 3 injections. And what I'm finding and what other people are finding is that, first of all, you don't need to do a series of anything for patients. There are patients who get better with 1 injection for a radiculopathy. There are patients who get better with 2, so I don't want to do more than I have to. It's just not appropriate. And it can take up to 1 or 2 weeks for that cortisone to really start working. And so I don't like to do it within 2 weeks anyway. So usually 2 weeks, sometimes 3 weeks is a good time frame of when you wait. Even though you're injecting cortisone into the epidural space, there is systemic absorption of the cortisone into the bloodstream. And so for patients with diabetes or other endocrine problems, you don't want to suppress their normal endocrine response. And so I don't like doing it within 2 weeks anyway. And so really probably 3 weeks is the perfect time frame. But if someone is in a lot of pain from a herniated disc and the first one just didn't work, I'll do the second one 2 weeks later. If it's for spinal stenosis pain, a lot of times because I'm so skeptical whether they really work or not, I'll do one and maybe a second one, but you'll never see me do 3 injections on someone with spinal stenosis. I'm more conservative with that.
So no relief, they get a second.
Well, it depends. So for hernia, that's a good question. So when I say no relief, I mean, patients are weird. They'll come back and they'll be like, I didn't get any relief. And you have to dig deeper. So I saw a patient yesterday, I didn't get any relief. And this was someone with leg pain, big disc herniation. I said, well, how did you feel for like immediately after the injection? Oh, I felt great for 2 days. Well, that's someone who has a herniated disc, has pain down the leg. More than likely, this person has a big inflammatory response. They probably need more than 1 injection anyway. So that's the person who I am willing to do more than one. And so the majority of patients who have radicular symptoms from a herniated disc, if it's a big disc herniation, the majority of patients are not getting completely better after one anyway. And so that's the person who I am willing to do 2 or 3 injections, and most of them get better.
What are you using for your anesthetic? Is it short acting or long acting?
Short acting. So I'm using short acting, I'm using lidocaine, and then I'm using dexamethasone. That's so a
Sometimes at 2 days, probably the cortisone doesn't get in.
Right. I mean, so it's hard to say, honestly. And there's some thought that maybe some of the fluid that you're putting in there is wiping away some of the inflammation. I mean, this is all like total theoretical stuff, but there's thought that some of the volume of fluid you're putting in is reducing the inflammation, and that's making the patient feel better. But if there's a big enough inflammatory response, then maybe you just need to do more than 1 injection. I mean, I think the bottom line is that know what you're treating. If you know you're treating something that this is good for, then I'm willing to be more persistent about doing more injections. If it's something that I'm skeptical about, I'm either going to say no or I'm going to be less likely to do more than one. People used to think that it was a disc mechanically pushing on a spinal nerve that caused radicular pain, and then people started realizing that, I mean, yes, that could happen, but also the inflammatory response is huge. So you could have a herniation that's not compressing the nerve or even touching the nerve and causing pain. And so it's just very, very variable. But again, disc herniations, therapy with epidural steroid injections, patients often are able to get better. Spinal stenosis, very unlikely, you know.
Are you using the term epidural and foraminal interchangeably?
So a transforaminal epidural steroid injection is a kind of epidural steroid injection. Like there's several kinds.
Is that what you're doing mostly now because you feel like the stenosis ones aren't as effective? Just dump it in the
No,
stage?
yeah, now we're getting into different, like whole different thing. But basically the evidence out there is that the thought is that doing a general epidural steroid injection, so just going straight through the midline, that they're not as effective as transforaminal epidural steroid injection. So a transforaminal epidural steroid injection is where you're going into the intervertebral foramen. An interlaminar epidural steroid injection is where you're going like straight through the midline, going through the ligamentum flavum. And in the old days, when people used to do the injections blindly, they used to have to go through the interlaminar approach because you couldn't get into there. How are you getting into something that small without any image guidance? And so the techniques have changed, and what people are starting to find is that when you go through the transforaminal approach and you actually target the nerve that's being irritated from an acute disc herniation, the outcomes are better. For spinal stenosis, whether you use the transforaminal approach, you know, let's say someone has narrowing in a very specific area, not all over their spine, but a very specific area, doing a transforaminal approach isn't necessarily any better than an interlaminar approach, and the outcomes are not necessarily much better, and they're just all bad, pretty much.
Same code for transforaminal?
No, it's a different code, totally different code. Yes.
If you're doing it for stenosis, are you more likely to go bilateral on that?
It depends on where the symptoms are. So I only inject the side where the symptoms are. Now, I'm just better trained at transforaminals because basically that's how I was trained, and I just don't find the interlaminars to be as effective. There are times when I will do an interlaminar or we'll do something called a caudal epidural steroid injection where you come up from below. I mean, there's certain cases. Someone's had spinal surgery before. Someone that just has so much narrowing in their neural foramen where you just can't get in. But essentially, if someone has pain down one leg, I'm doing a unilateral, just one-sided transforaminal. If someone has bilateral leg pain, then I'm either going to do a bilateral or I'm going to do more of a general epidural. Yeah, he has people probably.
Yeah, I mean, these are same to me, that is.
Well, that's good. At least we're all on the same page. Any other questions about epidurals? All right. So anyway, so we're going to talk about just generalized facet joint intervention. So the facet joint is they're little joints in the back of the spine. Um, they um, they become arthritic as people get older, and so kind of as a rule of thumb, I always say to patients, young people tend to get disc problems. Old people tend to get facet problems, and middle-aged people can get both. Makes it even more complicated. Now, there are several ways that you could treat facet pain from a procedural standpoint. One option is you could inject into the joint itself. Another option is you could do something called radiofrequency ablation, in which you are actually ablating or burning the nerves that send signals to and from the facet joints. There are some states, not our state, but there's some states out there that will not allow you or will not reimburse you for doing intra-articular facet joint injections. And the reason for that, the thought is that they're just not effective. Okay, and so they don't want to pay for them basically. And so imagine if you have a patient who is 75 years old, has axial low back pain, so pain in their back not going down their leg. 8:30. And so axial low back pain, usually it's pain in an older person that's worse with extension-based maneuvers. So standing and walking, okay, those are the big things that usually are painful, but not even always, but that's usually what it is. And so those are patients, chronic back pain, they can't walk, they can't stand, they do not have pain down the legs, it's just pain in their back. They've tried physical therapy, they're miserable, they can't walk on the golf course, they can't go shopping at the grocery store. They're not going to be necessarily a good surgical candidate because decompressing their spine is not going to improve their back pain, maybe their leg pain, but these are people without leg pain. So old people, arthritic sclerosed facet joints, what is the chance you're really going to get into that joint effectively through the capsule and have good relief from the pain of the pain? And the answer is probably not. And so that's why, I do not do a lot of intra-articular facet joint injections. Exception will be if someone is younger and just has very, very focal pain there, and that is not someone who I want to do an ablation on. So the next procedure is, and we're going to talk more in depth, radiofrequency ablation. So here you have 3 needles over here. They are right near where these medial branches are. So medial branches basically come off of the primary dorsal ramus of the spinal nerve and send pain signals to and from the facet joints. And so those are 3 needles hooked up to wires, and the wires then are hooked up to a radio frequency machine. And then after doing a little bit of testing, you actually do the ablation, which is a 90-second thing where the needle tips heat up to 80 degrees Celsius and basically burn these little nerves. Now, I call it a semi-permanent procedure. It's not permanent. The nerves do grow back over time. But if someone really has pain from the arthritic facet joints, then depending on their age, it can give them a pretty good relief of their pain. And so rule of thumb is that if someone is around 60 years of age, it can give them around 1 year worth of relief. If the patient is 70 or 80 years of age, it could hopefully give them 2 years worth of relief. And if the patient is under 50, do not do this procedure. I highly do not recommend it because the younger you are, the faster the nerves grow back and the faster the pain comes back. And so I've seen, unfortunately, the pain management industry is a little crooked at times. I've seen pain doctors do ablations on 22-year-olds, and those are patients who, by the way, why is a 22-year-old going to have an arthritic facet joint? It's just so unlikely. Most likely it's going to be other source of back pain, such as disc degeneration, disc bulging, annular tear, so disc back pain. Not going to get better with this, and now you're ablating their nerves, and it will grow back, but that's a patient who you just don't do it on.
You tend to do injections.
Like a test injection?
Yeah.
Absolutely. That's a really good question. So I wasn't going to go into it, but yes, you're asking a question. So before you do a procedure like this, so for an intra-articular facet joint injection, if I have a 28-year-old who comes in who has back pain and it's not getting better and it's painful with extension-based maneuvers and they've tried therapy and their MRI looks good, but there's maybe a little bit of arthritis of a facet joint, I'll just go into the joint and do an intra-articular injection with some corticosteroid and lidocaine. For someone who's older and you think that they may have pain from facet joint arthropathy, you don't just go right to this procedure. You do what's called a dual controlled, basically block, basically. So what you're doing is you're doing 2 different test injections, okay? So the proper way to do it is that you bring in the patient, you have them lie down on the exam table prone, you have the fluoroscopy machine, and instead of putting these certain type of special needles in there and hooking it up to the machine and burning the nerves, you're injecting lidocaine right in those areas, or some sort of longer lasting anesthetic. I tend to use bupivacaine. The right way to do it really is to use a high concentration of bupivacaine on one time, and then bring them back a second time and use a different anesthetic with a different duration, such as lidocaine. And what you're doing is you're saying, okay, you're coming in. This is not to treat your pain. This is to diagnose, to see if you are a candidate for radiofrequency ablation. And I'm going to inject some numbing medicine into your back, right where those nerves are that innervate or supply those facet joints. And what I want you to do immediately after you get out of the office is I want you to go shopping. Whatever, it's mood light, it doesn't matter. So I make the patient do something that aggravates their pain. So I make them walk around. I may have them go to Wegmans. I may have them go to Costco, walk around, or go to the park, walk around, do something that aggravates your back pain, and you have to keep a pain diary and let me know if your back felt better. So how long does lidocaine typically last for? Yeah, like 3-4 hours, 5 hours tops. It's a short-acting anesthetic. If the patient comes back to me and says, I had this injection, it was fabulous, I felt better for 12 hours, or actually I feel better still now, 1 week after the injection, would you say the injection was a positive diagnostic injection? The answer is no, exactly. And so whether they feel better or not, percentage of relief and duration of relief really matters, and it has to match up with the anesthetic that you're using. So for something like lidocaine, it should be anywhere between 3 and 5 hours worth of relief. If I'm using bupivacaine, it should be anywhere between 6 and 12 hours worth of relief. If it's anything more than that, then I'm very skeptical, and I start thinking that this is more discogenic back pain or just some other source of mechanical back pain, and they're not a candidate, and I don't go any further. So you really need to do 2 test injections, and I always do 2 test injections before ever considering an ablation. And even regardless, pain is so multifactorial. There are times I will do an ablation, and you really think it's going to work, and it just doesn't work. I mean, they're just not perfect, and back pain is so multifactorial. Yes.
What, do they need sedation?
No, actually, none of my patients need sedation for anything. The only times that I really feel like someone needs sedation is that person who's getting an epidural who has a huge disc herniation where I just feel like they're going to be miserable and uncomfortable. Other than that, I never sedate for a medial branch block. So like a test injection, because that they have to be awake and alert and be able to walk out of there and do things and walk around to see if this is working. And then for radiofrequency ablation, that the burning of the nerves, I actually I do testing of motor and sensory branches to make sure that we're not actually inadvertently burning like a ventral spinal nerve. And so the patient really should be awake for both. And so I never sedate for either of those.
And is your diagnosis of facet OA based on clinical, X-ray, or CAT scan, or combination?
Really good question. So it's very hard to diagnose clinically. It's very hard to diagnose radiographically. Every old person has facet arthropathy on an X-ray, an MRI, or a CAT scan. And so a lot of times it's clinical. So pain, walking, standing, completely better with sitting down. If someone starts saying, well, I also have a lot of pain when I'm bending and doing housework and getting out of bed in the morning and bending over to put on my shoes and socks, I start thinking that there's a big discogenic component. If I really think it's more extension pain, then I will bring them in for the test injections. And it's a way to prove to the patient whether they have it or not. And so a lot of times you just have to do these injections.
Specifically, you won't take?
I usually do not get a CAT scan. So again, this is facet joint procedures only helpful for chronic neck or back pain coming from the facet joints. I say rare because pain is so multifactorial, and especially chronic pain, that, I mean, it's just not as common as you would think it is. And again, the majority of chronic pain is really from a combination of multiple factors. So just targeting one little joint isn't necessarily going to fix everything. And again, chronic pain in general can have what we call, I like to use the word nociceptive. So nociceptive pain is I walk back to the office and I twist my ankle off the curb. That's nociceptive pain. That's holy crap, my ankle hurts, I can't walk on it. It's swollen, it's acute, it's inflamed. Non-nociceptive pain is basically pain that's no longer, so something that should not be hurting is hurting, okay? And no procedure is going to fix that. You know, that's someone who needs an exercise approach, maybe even a pain psychologist. The next procedure is a sacroiliac joint injection. Sacroiliac joint pain, in my opinion, is probably one of the most overdiagnosed things out there. I see all the time, this person has SI joint pain, this person has SI joint pain. I think the most important thing really for anything that you're going to find out is that if you don't know what the pain generator is, you shouldn't be doing an injection, or at least you should be open-minded in terms of that injection just may not be effective. So SI joint pain, there was a big study done by Paul Dreyfus out in the Washington area. He's a pain doctor, very well credentialed, and he wanted to see essentially where is the pain distribution for people who have SI joint pain. And what he found is that it could be anywhere. It could be in the butt. It could be down the leg. It could really look like pain from an acute disc herniation, but the one thing it cannot be is the pain cannot be above the belt line. So if the patient comes to you and says, I have pain up here and then it goes down my leg, it's not the SI joint. And that's really important because I see a lot of people both in and out of our practice diagnosing SI joint pain, and they clearly have pain above the belt line. It's not the SI joint. And so you have to really look for other sources. And so that's someone who could have pain from lumbar radiculitis. That's someone who could have pain from disc degeneration. And so you just have to make sure that you're not missing that disc injury. And for SI joint pain, a lot of times I'm basically looking at therapy before I'm even considering injecting the joint. And there are some people that are more prone to having SI joint pain. So patients who've had lower lumbar spinal fusions, you're now putting a lot of forces through the SI joint. So the patients who've had like the L5-S1 PSIF or the L4 through S1 PSIF, those are patients who legitimately could get SI joint pain and could actually benefit from treatment for that. But again, always start with therapy. Next procedure is something I do not personally do, but there are people out there who do it. It's called a spinal cord stimulator. This is the type of procedure that you do on someone as a last resort. This is not something you do on someone who comes in with like a 3-month history of radicular pain or any type of pain. This is the patient who most likely has had therapy, multiple injections, multiple surgeries. We call that, I guess you could say, failed back syndrome. And there are certain pain doctors who do it. Essentially, the patient has to undergo a trial before they could actually get the stimulator implanted by a surgeon. And so there are some pain doctors that will do the trial. And so what it involves doing is putting in the electrodes with the lead wires. It's maybe a little bit more invasive than an interlaminar epidural steroid injection. You're basically going into the epidural space and fishing the wire up into the spine, and you have to do a test and make sure that you're getting adequate coverage of the pain. And then you have the battery pack with the control taped to their back or taped to their body. And then what happens is you leave the trial stimulator in for 1 week, and if the patient likes it, then they'll be referred to a surgeon to get it implanted. If they hate it, they'll just take it out and not do it. There's some people that get them implanted that at first really like it and then hate it, and then they just let the battery run out and never get it changed. Think of it as an internal TENS unit. Basically, it's supposed to be blocking pain signals. And so it gives you a buzzing sensation like a TENS unit does. And there's some people who love the feel of that and are happy and they're able to wean off some of their opioids. There's some people who hate the feeling of it and want to go back to their opioids. And so again, this is something that's for that failed back case who's had multiple surgeries and everything else, and they're just not doing well.
I know you've done some of these.
Yes, we have a lot of those. Those are good ones.
Yep.
But sometimes patients come in, they do a spinal cord stimulator, but they miss the fact that the herniation or arthritis. But you got to do this as a last option.
Exactly.
Make sure there's nothing you can fix. So my thing is, we can fix it.
Correct.
And
totally.
after you've done a surgery, done the injection, whatever, and there's no other option.
Yeah.
Then this is the last thing because it doesn't fix it. It only covers it up.
Mm-hmm.
Electric type of pain medication. That's a good last option.
Right.
But if there's something to fix it before.
Absolutely. And that's the thing. I've had patients come in with big disc herniations and their neighbor said, oh, get a spinal cord stimulator. I'm like, this is crazy. I'm like, you don't do that. You deal with the disc herniation. And so it's just the problem is that everyone knows someone who's had a back problem. And because of that, everyone thinks they're an expert. And it's the most, I'm sure Dimitriades is like, it's frustrating. You actually have to spend more time educating your patient than anything else.
What would you say overall? Like, very good, all over the place.
It's kind of up and down. There's nothing to fix. Do the trial. You put one in temporarily for about 3 days. And then in those 3 days, if you feel good, those are the ones that put it in. They say, well, it was okay, not so good.
Yeah, don't put it in.
Don't do it. But I think the trial, 3 days before, the temporary lead in there, that's the most important thing. That works well, that put one in permanently. If not, don't do it.
Yeah,
Does it tend
totally.
to wear out over time, or
Usually, most of the times it works pretty well. Sometimes I told patients come back after a year, say something. That I don't have an answer. Sometimes they want out. But most people works well, but some people kind of take this as talking to in the head. They're not going to work for a long, long time.
Right. I've seen that a lot where patients will have like, oh, it'll work great for the first year, and then after that, it's, I mean, and that's, I don't know why, but yeah.
It's a psychological
Yeah, I agree. All right, and then the last procedure, do you do kyphoplasties?
Yes.
Yeah. So kyphoplasty. So these are for patients with compression fractures. Now, most patients, honestly, who come in with acute compression fractures, and again, the most common cause, so I tell patients all the time, there are three causes of compression fractures. One is bad bones, so osteoporosis. Another is trauma. And then the other cause, which is probably more common than anything else, is a combination of both things. So the old person who goes boom and falls and breaks something. A lot of patients I find are able to get away without getting this procedure done. You just manage them with some pain medication. Maybe you put them in a soft corset just for comfort. But there are some patients who have continued pain. Now, you're basically injecting cement in there, and it's a little controversial for chronic. Do you ever do it for chronic compression fractures? It's not as recommended for it. Acute, or acute or subacute.
Heal in about 3 months.
Right.
And the hardest thing I have to tell patients, because they want to get done right away.
Yeah.
But if I get talking to them, wait a little bit, after 3 months, usually get better. But when they don't, that's when I consider.
Yeah, I mean, so the patient, they come in, they've had the acute fracture, we diagnose it. Usually it's actually good that we're on the same page, which is good. Basically, what I tell the patient is it takes 3 to 4 months to heal. Your bones are brittle. It's going to take time. So pain medications, soft lumbar corset, I usually don't even put them in anything really hard. A lot of times they throw the corset in their closet. They don't want to wear the back brace. And then by the time they come back and see me in 6 weeks, they start feeling better. And then in 3 months, they feel good. There are occasionally those patients at the 3-month mark who don't do well, and they're still having pain. In those cases, I send them out to get the kyphoplasty done. Most people don't need it. There are some complications that you could have. My husband's coworker has a mother who had a compression fracture, and she just had a kypho done. She had, I guess, pain for 6 months. It just wasn't getting better. She developed a PE, so post-operatively. So, honestly, you just have to weigh the risk and the benefit. There are some doctors out there that will do kyphoplasties on people with chronic pain from chronic compression fractures. Not recommended. There are a lot of states, again, that will not cover it, which I can understand why not. Chronic compression fracture should not be causing back pain, and if you're getting back pain from that, it's probably non-nociceptive back pain or just mechanical back pain, and they need to do therapy and other things, but don't do this for that. And so pretty much that. So take home.
Do you get a follow-up MRI if they have consistent pain?
That's a good question. Sometimes I will. So I have had patients who've had persistent pain and they've refractured. I've seen it. It sucks. It happens. So you just have to take it all with a grain of salt. Like if I have a patient who's continuously having pain, or maybe they got better and then it got worse again, then I may do a follow-up MRI just to make sure that it's healed. If it's healed, then I could at least reassure the patient and tell them, look, we're going to do some therapy. If it's not healed or it looks like they refractured or re-aggravated, then that's someone who I may even consider definitely sending for kyphoplasty.
How long will the MRIs take, right, on a compression?
You know what? That's a really good question. I don't know the exact answer, but what I could tell you is that typically at the 6-week mark, radiologists start calling it subacute. And so normally by 6 weeks, you better start seeing healing, and so it might not be perfect, but the amount of edema and the amount of T2 signal that you're going to see is just not going to be what it is at the 1, 2, 3-week mark. And so the point is that 6 months later, it should not be lighting up at all. Yeah, and even 3 months later, really that thing should be healed or almost close to healed. And I've had I had a workers' comp guy who was a truck driver who basically fell on his back in between the truck, and he sustained a compression fracture. And just because he kind of didn't want to go back to work and was being a little persistent, I think was a little nervous, shocker, right? He's someone who I actually did get a follow-up MRI on just to prove to him that, look, this is healed, you're doing fine, your fracture's solid, you could go back to work. And so I don't usually get new MRIs, but it's those occasional situations where you do get a new MRI.
I think this is a tough one because I imagine if you did it, there's probably not a lot of indication to do it right away. But like if you wait 2-3 months, the fracture may be partially healed. So I would imagine it might be hard to get that height restoration.
That's true, but they usually heal on their own.
Right.
Most of these patients, they're not going to have people who do not need to, or parents. Older people with a lot of arthritis as well. So you have to separate the arthritic pain from the fractured pain.
Right.
And I think a lot of talking to the patients because a lot of them don't understand. They get rid of my pain.
Right.
So I understand.
Yeah, and really you have to figure out what their baseline is. If this is someone who has baseline back pain, I had a lady with a compression fracture. She has baseline chronic back pain, has had spinal fusion surgery before that. This lady's never going to be pain-free. And so you have to kind of set up the realistic expectation versus someone who's older, who's never had back problems, which is obviously a rarity. Their fracture's healed, they're feeling better. That's the perfect time to get them into therapy, to get them stronger. I'm not getting them into therapy, though, until that fracture is healed. That's the big thing that I feel.
Do you have a degree of compression?
No,
it's more the fracture. If it's been 3 months and it's still not considered kyphosis. Explain to them, listen, when we get to the way you were before the fracture, you understand, still have the same base pain, but the new pain from the fracture, we get rid of that, not the arthritic pain.
It's not indicated in my
No, that's going to be much harder because there's not much space to get in there. But usually with something like that, you give some time, it heals up, and it do much better.
Is there any indication for a bone stimulator for delayed healing fractures? Will the stimulation go that
No,
far?
not that I know.
Okay.
I usually bone stimulate more for fusion,
Right.
Heal, but not for compression. I've not heard of it.
Right.
All right, so any other questions about kyphos? Okay, so take-home points, spinal injections really should not be the first-line treatment. Exception is if the patient comes in with that acute disc herniation, they're writhing on the table, horrible pain down their leg or their arm, and they're so damn miserable that's one, in one case I will put them right on schedule. Spinal injections are often overutilized. And then I would just say for the PAs who are sending me patients, it's just, or sending any patient to an interventionalist, don't tell the patient they're getting an injection, tell them they're getting evaluated for an injection. So there are times when, and there are times when other doctors will send me patients and they tell the patient they're getting an injection and it might just be an inappropriate indication. And then I have to talk the patient off the ledge and they're already upset. And so anyway, and then also just never hesitate to ask me if you just don't know. Like I'm always available for you as a resource. So now we're moving on to electrodiagnostic evaluation, so also called EMG, nerve conduction. So there are two components of electrodiagnostic evaluation. One is the nerve conduction study, and the other is the EMG, which is the needle electromyography. Nerve conduction studies is where you deliver the so-called shocks to the patient. So you're using a surface stimulator, you're putting it on a limb, and you have electrodes hooked up, and you're basically stimulating a nerve, either a motor nerve or a sensory nerve, okay? And you're basically evaluating the integrity of the nerve sheath covering around an axon, so the myelin. So I always tell patients, I'm doing this part of the test to get a sense of how quickly the signal is getting from the spinal cord to where it needs to go. Okay, so you're looking at the speed of conducting of that nerve signal, okay? With needle EMG, you're using a small needle that has an electrode hooked up to it or within the needle. And what you're doing is actually evaluating the axon itself. So you're evaluating the nerve cell itself. And it's really through an indirect source. So you put it in muscle, you're evaluating how the muscle is functioning, which indirectly allows you to evaluate how the nerve cell is functioning. Now, this is just a diagram basically of myelin, which is the covering or the insulation around the axon, and that's the Schwann cell. Schwann cell is what produces the myelin. So this is like bringing it way back. So this is an EMG machine. Basically what you have is you have the actual EMG unit itself is here. This is just the computer stand and you have the printer. So this part is really irrelevant. This part is very, very important. An EMG machine is not cheap. It's probably around $30,000 to get a decent EMG machine. But they're nice because they're portable and I bring mine from office to office. So it is portable, which is nice. Now, there are certain diagnoses for which this is useful for. There are some that are not. Now, I'm limiting this to orthopedic diagnoses. I mean, yes, there are other types of neurologic diagnoses that EMGs could evaluate for ALS, among other things, but we're talking about orthopedic diagnoses. So the hand surgeons are my favorite referral source for EMGs, not to kiss Brian's butt or anything like that, but they're fantastic because for carpal tunnel syndrome and cubital tunnel syndrome, they are like the standard. That's the gold standard diagnosis. There's some people in the past who've talked about using ultrasound to evaluate for the integrity of the median nerve. So for carpal tunnel syndrome, and frankly, it's just not there, and it's never going to be there in my opinion. So carpal tunnel syndrome, cubital tunnel syndrome, radiculopathy with weakness, okay? If there's no weakness, evaluating radiculopathy is frankly not very helpful. Brachial plexopathy could be helpful for that new onset of foot drop to try to figure out whether it's a perineal neuropathy versus an acute L5 radiculopathy could be helpful. And then again, lumbar radiculopathy with obvious weakness. There are less than ideal diagnoses. So this is a test that is only used for peripheral nervous system disorders, okay? So anything from the central nervous system, the brain, the spinal cord, completely not useful for. So a good orthopedic example of which is not useful for this is cervical myelopathy. So that patient who comes in stumbling, tripping, clumsiness of their hands, you get an MRI, they have tightening, stenosis of the cervical cord, they've got myelomalacia, or they have some sort of cord edema, do not send them for an EMG because it's going to be negative. It's going to be completely a waste of time. That's a patient, honestly, who needs Demetriades, who needs spinal decompression. So no central nervous system disorder can be diagnosed with this test. Cervical and lumbar radiculopathies without any obvious weakness, very, very poor for this test. And so the funny thing is, the majority of the radiculopathy cases that are sent to me from our spine surgeon are actually cases where there's radiculitis, so not radiculopathy, so there's no weakness, just sensory findings, so numbness, tingling, dysesthesias, and pain. And I'm telling you, like, the test is almost always negative. And so what'll happen is I'll get a referral. Please do this EMG so you could help guide what levels I should be decompressing, let's say in the cervical spine or in the lumbar spine. And unfortunately, it's just not there. It's not helpful. It just does not evaluate for sensory problems. So for sensory radiculopathies, where just the sensory fibers are being injured, just does not work, unfortunately. Tarsal tunnel syndrome, very challenging. Thoracic outlet syndrome is tough, especially because thoracic outlet syndrome could have neurogenic causes, but also could have vascular causes, and the vascular causes tend to be more common, and so it's not necessarily effective for that. The big thing, so if you have a patient who comes in with pain down an arm or pain down a leg and it has not been worked up and they don't have any weakness, do not send that patient for an EMG. That's someone who needs a further workup, whether it be by me or an MRI initially, but that's just not something an EMG is going to be helpful for. So if it's just pain down an arm or a leg, you have no idea why it's there, more than likely you're not going to have a positive finding because it's more sensory symptoms. And then the other thing is, for generalized peripheral neuropathy, you could absolutely diagnose that diabetic or that older patient with the generalized peripheral neuropathy. So that's the patient who comes in and says, my feet are numb, I can't feel the balls of my feet. If it's really bad, it's ascending up to the shins and maybe even involves the hands. Yes, you could diagnose it, but what is it really going to do to manage your patient? And the answer is it's going to do nothing. Now, there are times when maybe Dr. Marsicano or maybe you actually want to get that EMG to prove to the patient that, okay, there's no nerve damage from the spine, and maybe that's just a way of I guess, convincing a patient not to get back surgery. I don't know if you ever feel that way at times. Right. Like maybe like just psychologically, like, and so in that case, it's reasonable, but that shouldn't be done like all the time. So, but there is a time and a place, obviously.
Just to go back, radiculitis versus radiculopathy.
Good. Let me explain that. Yes. So that's an excellent question. So a true radiculopathy is where someone has pain down a limb, weakness, and sensory findings, so sensory abnormalities that correlate to a very specific nerve root with pathology on their MRI. That is what a true radiculopathy is. So a lot of times we, as practitioners, use the term radiculopathy inappropriately. So a good example would be the patient with a big L4, L5 right paracentral disc herniation with a right foot drop. who can't pick up their toes. You get an MRI, it has that disc herniation. Their hamstring deep tendon reflex is absent. They have numbness over the L5 nerve root distribution. That is an example of an acute right L5 radiculopathy.
Pain, weakness, and
sensory loss.
So is the pathophysiology of that an axonal injury?
It's an axonal injury. That's a good question. So absolutely. So when you have weakness, it's an axon loss. Okay. When you have sensory problems, it can be an axon loss. The problem is that with sensory fibers, they're small fibers. EMG is not good for small fiber diagnoses, which is why it's hard to diagnose autonomic nervous system issues with that. And so essentially radiculopathy, think of neurologic issues that correlate to an MRI. And with radiculitis, think of that MRI that shows that disc herniation, but there's just pain, but there's no weakness and there's no sensory loss, okay? And so there's a very big difference. And so if someone has radiculitis, meaning they have pain, let's say from a herniated disc, that EMG is almost certainly going to be negative. If someone has radiculopathy with true weakness and it's an obvious foot drop, most likely the EMG is going to be positive. Okay?
I mean, it makes sense that pain is itis.
Right.
Motor is
apathy.
But what about sensory? Where does that
It
fall?
just doesn't. The problem, I mean, it's so.
It's a gray area.
It is a gray area, and the problem is that because EMG doesn't do a good job of evaluating for small fibers, you're not going to find it on there, and that's what sucks because the majority of radiculitis or radiculopathy involves sensory fibers, not motor fibers, and that's where the problem is, and which makes it tricky because look, I would love to tell Dr. Marsicano, okay, there's pathology at the C4/C5 and C5/C6 levels. You only need to do a one-level decompression with fusion. I would love to be able to tell him that, or you go in and do both levels. It's just almost impossible to give him that certainty, and it sucks because you wish you could do that because it would actually mean something for the patient. It really would. Again, we went through this, but radiculopathy, very important, only useful for motor radiculopathy, so I cannot hammer it home enough. So you guys, Amanda, you work with Dr. Marsicano, you're going to have a talk with Dr. Marsicano today. If someone comes in and they have pain down an arm or a leg, some some MRI findings, and there is no weakness, and an EMG is not going to help him make a surgical decision. Now, if he wants that EMG because he wants to convince the patient that they're fine and he thinks the patient's FOS, we know what that means, then get the EMG, that's no problem, but just so that he's aware of that. And then the other thing I would say is that if it's obvious, so if someone has that big L4, L5 disc and has a foot drop and it's all matching up, everything is matching up, then we don't need an EMG. It's completely useless. The only caveat would be is if you're worried that you want to figure out prognosis for recovery. So if the patient comes in, has a chronic disc, they've had foot drop, you think they've had this foot drop for the past 1 year, it wouldn't be a bad thing to get that EMG just to see what the baseline function is, because I can look at EMG and give the surgeon an idea of how well or how likely it is that nerve function is going to recover. And that could be important. From a medical legal standpoint, it could be important just talking to the patient.
You do an NCD on that patient just to rule out?
I do to rule out. Right, absolutely. So like especially, and I always do nerve conductions, I always do. I think it's important to be complete. The patient's happy. And again, if there's any other reason why the patient could have a foot drop, do it. Make sure that it's not that as well. And then there are other times where patients come in and they just have weakness and you don't know why they have weakness. And sometimes an EMG could help with that. And so brachial plexopathies actually do happen. And so, whether someone's had a Parsonage-Turner syndrome, so some sort of a virus. So I have had Dr. Law is like the king of sending me unusual weakness patterns for some reason. I get a lot of that from him. She's laughing because she knows it. Things that you say to a patient who's getting an EMG, because patients often get really nervous. They talk to their neighbors and, it's the most uncomfortable test. This is not an excruciating test. It's mildly uncomfortable. So I tell patients all the time, when you're doing the stimulation portion of the test, so the shocks, it's uncomfortable. So have you ever touched a staticky doorknob and you're like, I felt that shock? That's what it feels like, okay? So it's kind of an annoying nuisance feeling for the patient, but it's not ridiculously painful. The needle that I use is the size of an acupuncture needle, is not ridiculously painful. Needles in the hands and the feet are more painful than needles in meatier areas of the body. So if I have to go there, that's the last thing I'm doing so that the patient is not freaking out. And then also, they can drive to and from the test. They can have a pacemaker. They can be on anticoagulants. I mean, none of that is a problem. But I always tell the patients, no creams or lotions. It could actually harm the conduction part of the test because you have a barrier there. Now, there are certain contraindications of why you would not send a patient for an EMG. If they're just unable to get on a table for me to do the test, so they can't lie down on a table and they're completely immobile, probably not the right test to do on them. If there are open wounds, open rashes, anything that's like over the limb that you're studying, definitely a contraindication. If the patient is just extremely anxious and can't handle it mentally, then that could be a problem. If it's just someone who's nervous, that's not a problem. If someone has a lot of swelling or edema of their limbs, so that patient who's older, who has a lot of just puffiness of their legs, the nerve conduction studies might as well not be done because they're going to be completely useless because you have a fluid barrier and you're just not going to get any readings. And again, pacemaker and blood thinners are not contraindications. You could do the test. So take-home points, it's a little bit of an uncomfortable test for the patient, but it's usually well tolerated. It's really the best for carpal tunnel, cubital tunnel, that acute foot drop or acute weakness coming from an orthopedic source. It's often over-ordered. I think tests and procedures, unfortunately, in our society are just over-ordered in general. And again, if you're not certain, just ask me if you just want to know if it's appropriate or not. I'm always happy to answer. So that is it. So any questions that you guys have?
It's funny you say that because I feel like some of whoever orders they probably have a little ridiculous. Mm-hmm. They order an EMG. It's not going to show anything up here. Their carpal tunnel is like 4.3 on the motor, mm-hmm. like 3.5 on the sensory, and then they send them to me because they say, oh, it's carpal tunnel.
Well, what I will tell you, and that's a really good point. So what Brian is saying is you could incidentally pick up anything, right? So carpal tunnel, if you were to take 100 people off Jack Martin Boulevard who are 50 plus years of age without any symptoms, I'd probably find some degree of carpal tunnel in 50% of them. It's just an age-related diagnosis. Now, having said that, what I will tell you is, just to help you guys out, I always, when I'm doing that test, I talk to the patient. I try to get a sense of really what is the cause. So you may see me when I do a report and put it together, I may say abnormal test, but clinically irrelevant. So that's the patient who has pain up here, has no numbness and tingling in their hand, doesn't wake them up at night, they're not losing grip strength, they don't have any issues with that. I do the test and they have some mild carpal tunnel. That is not someone who needs to get a carpal tunnel release, okay? However, there are times where I will incidentally find carpal tunnel, the patient's more complaining of this, but then if I dig deeper and I'm seeing, oh wow, they have moderate carpal tunnel, are you getting numbness and tingling of your hand at night? Yeah, actually I am. Are you shaking it out? Yes, I am. Are you dropping things like car keys? Do you feel like your grip strength is not as good? Yeah. Well, carpal tunnel is a progressive disorder. It gets worse over time. There's really a sweet spot for doing the decompression. And so if you wait too long, you could get permanent nerve damage. So, I mean, I'm not saying that waiting an extra 6 weeks is going to matter, but if you wait a few years after it's diagnosed as moderate, you could develop permanent damage. If you do it too early on, the patient's not going to get better because they probably never had symptoms from it to begin with. And so that's why I always talk to the patient to get a sense if it's really relevant or not relevant, because I don't want to send the patient to someone to get a surgery if it's not going to be relevant or not. So that's why you talk to the patient.
You use a lot of these? Actually, I don't use the EMGs a lot. I use it if I'm thinking there's a couple of discrepancies, I don't know which one's causing symptoms. I'm going to do surgery. I might do it, but I don't use EMGs all that often. You need to know what's going on and not rely on EMG. It can be confusing. You have to know what's going on.
Yeah, I mean, and there might be the patient who has, some cervical, maybe some cord impingement, but not edema. So they have stenosis on their MRI, but then it's saying my hands are numb and tingly. Well, better make sure it's not carpal tunnel causing that before just, you know what I mean? So like he's looking for other causes, other sources, and it makes perfect sense. He doesn't want to do surgery on someone if he doesn't think it's going to help. So, all right. Again, if you have any questions, just please don't hesitate to ask.
That was great.
Thanks.
Really, thanks.
Awesome. All right, absolutely.
Yeah.